Next, we have Dr. Sugarang Ranjini presenting on a rare case series of coexisting keratoconus and PMD in a single eye. Okay.
Sugaranjan. Good afternoon to one and all. At the outset, I would like to thank KSOS for giving me this opportunity. And today I'll be presenting on a rare case series of patients with coexisting keratoconus as well as pellucid marginal degeneration in the same eye. 10% of the patients with pellucid marginal degeneration are reported to be associated with keratoconus, but little is known about their characteristics. So we set out to do exactly that, to study the ophthalmic characteristics and treatment outcome for patients with coexisting PMD and keratoconus. So our diagnostic criteria was slit lamp examination showing the presence of two areas of thinning, that is a band-shaped peripheral corneal thinning, along with a central or paracentral stromal thinning and clinical features suggestive of PMD and KC. Scheimpflug imaging as well as anti-segment OCT confirmed the documentation of the two areas of thinning. Topographic features were studied, but they were not included in our diagnostic criteria. So it was a retrospective analysis, and 7 eyes of 5 patients were enrolled. All the eyes had inferior band of thinning documented on slit lamp, Scheimpflug, as well as anterior segment OCT. The mean age of the patient was 37 years. They were predominantly males and they had a unilateral presentation. And in cases with unilateral presentation, had a association of keratoconus in their contralateral eye. And all patients had features of keratoconus in their central cornea. In the interest of time, I'll be discussing 3 cases only. This is a 33-year-old female who presented with warts in the central cornea with scarring and thinning, along with an inferior thinning. This was documented even on Scheimpflug images where central and inferior thinning was picked up. And this is also so beautifully shown in the anterior segment OCT. The topographic feature is not included in our diagnostic criteria, but as we can see in this particular eye, the topography does not fit into either of the diseases. And the contralateral eye showed features of keratoconus, and in Scheimpflug imaging, an inferior thinning was not noted. This patient underwent deep anterior lamellar keratoplasty with a large diameter graft and had a good visual outcome. This is a 44-year-old male who presented with a central corneal scarring and thinning, and also with an inferior thinning suggestive of a KC and a PMD in the same eye. The Scheimpflug image again shows the two areas of thinning in the same eye, also beautifully picked up on an anterior segment OCT. The topography again does not fit into either keratoconus or a pellucid, and the contralateral eye shows features of keratoconus. And this patient underwent a penetrating keratoplasty followed by cataract surgery many years later with an IOL implantation. And again, a large diameter graft was used, and he had a good visual outcome. This is a unique case where there was a bilateral presentation. In this, as we can see from in the left eye, there was a central as well as an inferior thinning picked up on Scheimpflug, and in the right eye was not such an advanced disease, and the thinning was much more subtle. Since the left eye had an advanced inferior thinning, we went ahead and did a sclerocorneal intralamellar keratoplasty in this eye to strengthen the inferior cornea. And then we did the central corneal cross-linking for control of the keratoconus in the central part of the cornea. In the other eye, only corneal collagen cross-linking was done, but with a wide area of epithelium removal, and a large diameter UV beam of 9 mm was used with limbus protection. Again, the topography features don't fit into anything in particular. And this patient did not have a significant visual outcome as compared to the penetrating keratoplasty and DALK patient, and she was advised to use contact lenses. So coming to the discussion, keratoconus with pellucid marginal degeneration has been reported as far back as in 1984, where 17 patients of PMD were noted to have KC in their central portion of the cornea. And this large retrospective study of PMD conducted in LV Prasad Institute in India agrees with our findings of a male association and a weak association of allergy present in these patients. In a national survey of pellucid marginal corneal degeneration done in Japan, when they studied the contralateral eyes topographic features, patients with PMD were seen to have features of keratoconus in their contralateral eye. So this agrees with what we have also found in our study, that is unilateral cases can be associated with keratoconus in the other eye. So as we all know, and as illustrated by Lee et al., the claw-shaped pattern is not, diagnostic of PMD. And if one is relying only on a topographic pattern to diagnose a case of PMD in this coexisting pathology, it can be easily missed. And as we stressed in our diagnostic criteria as well, it is a diagnosis is mainly clinical using slit lamp and probably a Scheimpflug or an ASOCT. So what we propagate is that always look at the inferior part of the cornea also. When you're transplanting these patients, use a large diameter graft so that you include the area of pellucid as well. And early cross-linking of the contralateral eye is prudent. The limitation of our study is that the corneal topography that we used gives us only a 9 millimeter pachymetry map. A 12 millimeter pachymetry map would have been ideal to study the changes of a pellucid, but this was not provided by our map. So in conclusion, pellucid marginal degeneration can coexist with keratoconus, and it is vital to include all areas of thinning while planning a corneal transplantation in such patients. This is mainly to educate the coexistence of this entity and to spread awareness about it. Thank you so much.